Steroid use in autoimmune diseases is a cornerstone of treatment, aiming to control inflammation and suppress immune activity. The guidelines vary depending on the specific condition, severity, and treatment goals. Below is a general overview with a focus on pulse steroids, oral steroids, their doses, duration, and routes of administration. 1. Pulse steroid therapy. Definition: high dose intravenous IV corticosteroids, e.g., methylprednisolone, administered over a short period, usually 3 to 5 days. Indications: pulse therapy is typically used in severe or life threatening flares of autoimmune diseases, such as lupus nephritis, severe rheumatoid arthritis, multiple sclerosis relapses, vasculitis, or in cases where rapid immune suppression is needed. Common regimen: methylprednisolone, 500 milligrams to 1 gram IV daily for 3 to 5 days, sometimes followed by a gradual tapering with oral steroids. Monitoring: pulse therapy should be used with caution in patients with cardiovascular disease, diabetes, or osteoporosis, as high doses can lead to significant side effects like hyperglycemia, hypertension, and electrolyte imbalances. 2. Oral steroid therapy. Indications: used for moderate autoimmune disease flares or maintenance therapy for chronic autoimmune conditions. Commonly used steroids: prednisone, prednisolone, methylprednisolone. Dosing and duration: initial doses varies with the condition and severity. Mild to moderate disease: prednisone 5 to 20 milligrams per day. Severe disease: prednisone 40 to 60 milligrams per day. Tapering should start once the symptoms begin to improve. Maintenance therapy: a lower dose of 5 to 10 milligrams per day may be used for chronic management to minimize the risk of long-term side effects. Tapering: gradual tapering is crucial to prevent adrenal insufficiency. Tapering schedules vary, but may involve reducing the dose by 2.5 to 5 milligrams every 1 to 2 weeks, depending on the duration of therapy and clinical response. Short courses: burst therapy. Prednisone 30 to 60 milligrams daily for 5 to 10 days without tapering for short-term control of inflammation in conditions like acute flares of rheumatoid arthritis. 3. Duration of therapy. Short-term therapy, typically less than 2 to 3 weeks, often used for acute flares. Intermediate duration, 1 to 3 months, used for more persistent cases. Long-term therapy, more than 3 months, typically reserved for chronic conditions where disease control cannot be achieved without steroids. This requires careful monitoring for side effects such as osteoporosis, hyperglycemia, and infections. 4. Routes of administration. Intravenous, IV, used for pulse therapy or when rapid action is needed. Methylprednisolone is the preferred choice due to its potency and reduced mineralocorticoid activity. Oral, most commonly used route for convenience and patient compliance, preferred for long-term or tapering regimens. Intramuscular, IM, less commonly used but may be considered in patients who have difficulty adhering to oral medication or in cases where rapid but not immediate onset is desired. Important considerations: monitoring. Regular monitoring is essential for patients on long-term steroid therapy. This includes bone density assessments, blood sugar levels, blood pressure, and electrolyte levels. Prophylactic measures. To reduce side effects, calcium and vitamin D supplementation is often recommended. Prophylaxis against osteoporosis with bisphosphonates may be indicated in patients on long-term steroids. Consider using proton pump inhibitors, PPIs, for gastrointestinal protection. Adrenal suppression risk. Long-term or high-dose steroids can suppress the hypothalamic pituitary adrenal HPA axis, necessitating a slow tapering process to allow adrenal recovery. These guidelines serve as a general framework, but therapy should be tailored to the individual patient's condition, comorbidities, and response to treatment. Always consider consulting specific guidelines for the disease in question, e.g., ACR guidelines for rheumatoid arthritis, lupus, and the patient's overall health status. The maximum beneficial dose of oral corticosteroids varies based on the condition being treated, but generally, it refers to the highest dose that effectively controls symptoms without causing excessive side effects. For most autoimmune diseases, doses above a certain threshold provide diminishing returns in terms of benefit, but significantly increase the risk of side effects. Here's a breakdown. 1. Prednisone prednisolone. Maximum beneficial dose, usually 40 to 60 milligrams per day. Doses in this range are used for severe flares, such as in systemic lupus erythematosus, SLE, vasculitis, or polymyositis. Beyond 60 milligrams per day, the benefits tend to plateau while the risk of adverse effects like hyperglycemia, hypertension, psychiatric symptoms increases. Hack 2. Higher doses. Doses above 60 milligrams per day are rarely used long term. In situations like acute severe disease where immediate control is required, higher doses, e.g., 1 milligrams per kilo per day, may be used initially, but are quickly tapered to a lower maintenance dose as soon as clinical improvement is noted. For instance, in giant cell arteritis, doses up to 1 milligrams per kilograms per day, up to 60 milligrams done, are used until symptoms resolve. General considerations. The goal is always to use the lowest effective dose for the shortest possible time to minimize side effects. Long-term use of high doses, e.g., above 20 milligrams per day, significantly increases the risk of complications like osteoporosis, infections, and adrenal suppression. If a patient does not respond adequately to doses in the range of 40 to 60 milligrams per day, other immunosuppressive or biologic agents are typically considered rather than further increasing the steroid dose. Each patient's needs may vary, so it's critical to assess the balance between benefits and risks, adjusting the treatment plan as needed. The idea that increasing the dose of prednisolone from 30 milligrams to 60 milligrams has a limited increase in therapeutic benefit but carries a higher risk of side effects is generally based on evidence rather than a myth. Here's a breakdown of the reasoning. 1. Dose-response relationship. Plateau effect. The anti-inflammatory and immunosuppressive effects of glucocorticoids, like prednisolone, tend to reach a plateau as the dose increases. This means that after a certain point, higher doses provide only marginal additional therapeutic benefits. For many autoimmune conditions, the effective control of inflammation can often be achieved with doses around 30 milligrams per day. Increasing the dose further to 60 milligrams per day may not necessarily double the anti-inflammatory effect, but can double the exposure to side effects. Dose-dependent side effects. Steroid side effects such as hyperglycemia, hypertension, mood changes, insomnia, weight gain, muscle weakness, and increased risk of infections are dose-dependent. This means that doubling the dose can significantly increase the likelihood of these side effects. High dose threshold. Doses above 30 milligrams of prednisolone per day, especially sustained over time, tend to markedly increase the risk of adverse effects without proportional increases in therapeutic gains. 3. Clinical practice and guidelines. Guidelines and clinical practice often recommend starting at the lowest effective dose for conditions like rheumatoid arthritis, systemic lupus erythematosus, or polymyalgia rheumatica, and then tapering down as soon as possible. For example, in cases of moderate disease activity, 30 milligrams a day might suffice, while more severe cases may initially require higher doses, up to 60 milligrams per day. However, such higher doses are typically reserved for acute severe flares or life-threatening conditions and are not maintained long-term because of the side effect burden. Summary. Fact. The difference in therapeutic benefits between prednisolone 30 milligrams and 60 milligrams is not proportionate to the increase in potential side effects. The risk of side effects increases significantly with higher doses, while the additional benefit may be marginal. This is why many clinicians prefer using a dose like 30 milligrams when possible, and only increase to 60 milligrams when absolutely necessary, typically in the short term, until the disease is under control. This approach allows for effective management while minimizing the risk of adverse outcomes, aligning with the principle of using the lowest effective dose for the shortest duration. The difference between using 500 milligrams and 1,000 milligrams of intravenous IV methylprednisolone in pulse steroid therapy is an important consideration, as it involves balancing potential side effects with therapeutic gains. Here's a closer look at the nuances of this dose difference. 1. Therapeutic effect. Ceiling effect. Similar to oral steroids, IV methylprednisolone has a ceiling effect in its immunosuppressive and anti-inflammatory actions, meaning that beyond a certain dose, further increases yield diminishing returns in terms of efficacy. 500 milligrams versus 1,000 milligrams. Clinical experience and some studies suggest that both 500 milligrams and 1,000 milligrams doses of IV methylprednisolone can be highly effective in managing severe autoimmune flares, e.g., lupus nephritis, severe multiple sclerosis relapses, vasculitis. However, the additional benefits from increasing the dose to 1,000 milligrams may not always be significantly better than 500 milligrams. The choice between these doses often depends on the severity and urgency of the condition. For instance, 1,000 milligrams may be preferred in more severe or life-threatening scenarios where maximal immunosuppression is needed quickly. 500 milligrams may be used in cases where rapid control is needed, but the situation is less severe. 2. Side effect profile. Acute side effects. High-dose IV steroids can cause acute side effects, including fluid retention. Higher doses increase the risk of hypertension and fluid retention. Electrolyte disturbances, such as hypokalemia. Hyperglycemia, particularly in diabetic or pre-diabetic patients, the rise in blood sugar can be more pronounced with 1,000 milligrams. Mood and psychiatric changes. High-dose steroids can cause acute psychosis or severe mood swings, which may be more likely with a 1,000 milligrams dose. Long-term risks. Even though pulse therapy is short-term, repeated courses at higher doses, e.g. 1,000 milligrams, can contribute more significantly to long-term risks like osteoporosis and increased susceptibility to infections. Number 3. Clinical practice and considerations. The decision to use 500 milligrams versus 1,000 milligrams is often based on weighing the potential marginal benefit of a higher dose against the increased risk of side effects. If the clinical scenario suggests that the additional immunosuppression of 1,000 milligrams is crucial, e.g., severe organ-threatening manifestations like aggressive lupus nephritis, then the higher dose may be warranted. In contrast, for less severe flares or in patients who are particularly vulnerable to side effects, 500 milligrams may be chosen as it still provides significant immunosuppressive action while potentially reducing the risk of acute adverse events. Summary. Fact. Increasing the dose from 500 milligrams to 1,000 milligrams of IV methylprednisolone does increase the risk of side effects, e.g., hyperglycemia, mood changes, without a proportionate rise in therapeutic benefit for many conditions. Clinical judgment. The choice between these doses should be individualized, considering the severity of the disease flare, the patient's risk profile for side effects, and the urgency of achieving immune suppression. Using the lowest effective dose remains a general principle, even with pulse steroids, unless the clinical scenario justifies a higher dose. In conclusion, the increased risk of side effects with higher pulse doses, 1,000 milligrams versus 500 milligrams, should be carefully balanced against the clinical need, aiming to provide adequate treatment without undue risk. The classification of steroid doses into categories like low, moderate, high, very high, mini pulse, and pulse therapy depends on the specific type of steroid used and its potency. Below is a classification using prednisone or prednisolone equivalents, which is commonly used in clinical practice. 1. Low dose. Prednisone prednisolone equivalent, up to 7.5 milligrams per day. Use. Often used for maintenance therapy in conditions like rheumatoid arthritis or systemic lupus erythematosus, SLE, when the goal is to keep inflammation under control with minimal risk of side effects. 2. Moderate dose. Prednisone prednisolone equivalent, 7.5 milligrams to 30 milligrams per day. Use. Typically used for moderate disease activity or flares where more immunosuppressive activity is needed. For example, this dose range might be used for treating polymyalgia rheumatica or during a flare of lupus. 3. High dose. Prednisone prednisolone equivalent, 30 milligrams to 60 milligrams per day. Use. Used for more severe flares or conditions where rapid control of inflammation is needed. This range is often used for more active lupus nephritis, severe rheumatoid arthritis flares, or moderate to severe vasculitis. 4. Very high dose. Prednisone prednisolone equivalent, 60 milligrams to 100 milligrams per day. Use. usually reserved for severe disease states where high immunosuppression is required, such as life-threatening vasculitis or severe organ involvement in lupus. Long-term use at this level is rare due to high risk of significant side effects. 5. Mini pulse therapy. Prednisone prednisolone equivalent, 125 milligrams to 250 milligrams intravenously, IV, daily for 1 to 3 days. Use. Often used when a quick, short burst of immunosuppression is needed, but not to the extent of a full pulse therapy. This might be used in moderate flares of diseases like multiple sclerosis or lupus with less severe organ involvement. 6. Pulse therapy. Methylprednisolone equivalent, 500 milligrams to 1,000 milligrams IV daily for 3 to 5 days. Use. Reserved for severe, life-threatening conditions such as lupus nephritis, severe vasculitis, or rapidly progressive glomerulonephritis. It aims for rapid immune suppression and inflammation control when immediate action is needed. After pulse therapy, a transition to oral steroids with tapering is common. Summary table. Category: dose, prednisone, prednisolone equivalent. Use of tapering is common. Low dose, up to 7.5 milligrams per day. Maintenance therapy for mild inflammation. Moderate dose, 7.5 milligrams to 30 milligrams per day. Moderate disease activity or flares. High dose, 30 milligrams to 60 milligrams per day. Severe disease flares. Very high dose, 60 milligrams to 100 milligrams per day. Severe or life-threatening conditions. Mini pulse, 125 to 250 milligrams IV daily for 1-3 days. Quick burst therapy for moderate flares, pulse therapy, 500 to 1,000 milligrams IV daily for 3 to 5 days. Severe life-threatening conditions. This classification is widely used to tailor therapy based on the severity of the condition and the need for rapid immunosuppressive action, while also managing the risk of potential side effects.